Now that we have studied the soft tissue and the surface landmarks of the foot and ankle, let's move deeper into the osteology of this region. Understanding the bones and their articular surfaces is essential not only for surgical approaches, but also for interpreting radiographs and recognizing patterns of injury. In the anterior view of the ankle, we can see the two main bony prominences, the lateral malleolus of the fibula and the medial malleolus of the tibia. These form the bony framework of the ankle joint, providing stability and guiding the talus in its articulation. Between them, we can identify the articular facets of both malleoli, which articulate directly with the talus. Looking at the posterior view, we notice the groove for the tibialis posterior and flexor digitorum longus tendons, located behind the medial malleolus. This is clinically important. Inflammation or compression in this area can cause tarsal tunnel syndrome. We can also see the posterior colliculus and the posterior tubercle of the distal tibia, which provide attachment points for key ligaments, such as the posterior tibiotalar ligament of the deltoid ligament. From the superior view, the talus becomes the central focus. Here, you can appreciate the trochlear surface of the talus, which is covered in cartilage and articulates with the tibia. Notice the sustentaculum tali, projecting medially from the calcaneus. This structure acts as a shelf, supporting the talus above and serving as a pulley for the flexor hallucis longus tendon. The superior view also highlights the fibular or peroneal trochlea on the lateral side of the calcaneus, guiding the peroneal tendons as they descend. The lateral view provides a very practical perspective. Here, the tuber angle and the critical angle of Gissane are illustrated. These angular measurements are crucial in radiographic assessment of calcaneal fractures. Normal values are essential for differentiating between subtle deformities and significant injuries that require surgical intervention. Now, let us review the ossification and fusion characteristics of these bones, which are clinically relevant, especially in pediatrics and adolescent orthopedics. For the distal fibula, the lateral malleolus begins ossification around 4 years of age and fuses between 18 and 20 years. This region is the site of insertion for the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. Because of these ligamentous attachments, small avulsion fractures are common here, especially in inversion injuries. For the distal tibia, the weight-bearing portion known as the plafon begins ossifying around 1 year of age and fuses between 18 and 20 years. This concave surface is congruent with the talar dome and critical for ankle stability. Unique fractures of the distal tibia are seen in adolescence due to the asymmetric closure of the physis. These include the famous Talot fracture, involving the anterior tibial tubercle, and the triplane fracture, which often includes the posterior tibial tubercle as well. The medial malleolus has two important bony prominences, the anterior and posterior colliculi. These provide attachment to the deltoid ligament, one of the strongest stabilizers of the ankle. The superficial fibers attach to the anterior colliculus, while the deeper fibers extend posteriorly, ensuring medial ankle stability. Moving to the calcaneus, this is the largest tarsal bone and the foundation of the hindfoot. Ossification begins as early as 6 months in fetal life, with secondary centers such as the calcaneal tuberosity appearing around 9 years and fusing between 13 and 15 years. Clinically, the calcaneus is notable for several radiographic landmarks. For example, Bowler's angle, normally between 25 and 40 degrees, is reduced in calcaneal fractures. Similarly, the critical angle of Gissane is used to evaluate deformity of the posterior facet. The peroneal tubercle on the lateral aspect guides the peroneal tendons, while the sustentaculum tali provides medial support for the talus and acts as a fulcrum for the flexor hallucis longus tendon. Finally, take note of the multiple articular facets of the calcaneus. The posterior facet is the largest and the one most frequently involved in intra-articular fractures. The middle and interior facets, along with the sustentaculum tali, form part of the subtalar joint complex, critical for inversion and emersion of the foot. In summary, the osteology of the ankle and hindfoot demonstrates the delicate balance between bony congruence, ligamentous support, and articular surfaces. A thorough understanding of these relationships is essential for recognizing injuries, planning surgical approaches, and interpreting radiographic findings. In the next section of our lecture, we will continue to explore the deeper joints and articulations of the foot, linking these anatomical details to their clinical significance. Now, let us carefully study the midfoot bones, which form the crucial transition between the hindfoot and the forefoot. In this section, we will focus on the talus, navicular, cuboid, and the three cuneiform bones, as seen from both the lateral and medial views. The talus. The talus is a fascinating bone because, unlike most others, it has no muscular attachments. Instead, it is entirely enveloped by articular cartilage and sustained by ligaments. In the lateral view, we can identify its body, neck, and head. The trochlea of the talus articulates with the tibia and fibula, forming the ankle joint proper. From the medial perspective, the talar head articulates with the navicular bone, supported inferiorly by the spring ligament. This connection is vital for maintaining the medial longitudinal arch of the foot. The table reminds us that the talus begins ossification as early as 7 months of fetal life, and the body fuses between 13 and 15 years of age. Clinically, the talar neck is one of the most critical regions because it serves as the entry point for the blood supply to the talar body. This is why fractures of the talar neck are so dangerous. They interrupt retrograde blood flow, predisposing the talus to avascular necrosis. Another point to remember, the posterior process of the talus is divided into medial and lateral tubercles, with the groove for the flexor hallucis longus tendon running between them. The lateral tubercle, when enlarged, forms the os trigonum, an accessory bone that can cause posterior ankle impingement, especially in ballet dancers or athletes who frequently plantar flex the foot. And finally, the lateral process of the talus is sometimes called the snowboarder's fracture site because of its vulnerability to high-energy dorsiflexion and inversion injuries. The navicular. Next, let's examine the navicular bone, named for its boat-like shape. This bone is positioned medially between the talus posteriorly and the three cuneiform bones anteriorly. The navicular ossifies around 4 years of age and fuses by 13 to 15 years. Its most recognizable feature is the navicular tuberosity, which projects medially. This is the insertion site of the posterior tibial tendon, an extremely important tendon for arch support. Dysfunction of this tendon leads to collapse of the medial longitudinal arch and acquired flat foot deformity. The navicular is often referred to as the keystone of the transverse arch of the foot. It plays a central role in redistributing forces between the medial and lateral columns. Clinically, the navicular can be affected by stress fractures in athletes or by Köhler's disease, which is an osteonecrosis of the navicular seen in children. These pathologies highlight its importance in weight-bearing and locomotion. Now we turn to the cuboid bone, located on the lateral column of the foot, articulating with the calcaneus posteriorly and the bases of the 4th and 5th metatarsals anteriorly. The cuboid ossifies at birth and fuses between 13 and 15 years of age. Its inferior surface is marked by the groove for the peroneal longus tendon, which wraps around the cuboid, creating a pulley system that helps maintain the transverse arch of the foot. Because of its central location in the lateral column, the cuboid plays a role in stability during gait. One clinical syndrome worth noting is the cuboid syndrome, where subluxation or malalignment of the cuboid causes lateral foot pain, commonly seen in dancers or athletes. And finally, we reach the three cuneiform bones, medial, intermediate, and lateral. Together, they form the anterior portion of the medial column, articulating with the navicular proximally and the first 3 metatarsal bases distally. The medial cuneiform is the largest. The intermediate cuneiform is the smallest, and the lateral cuneiform lies adjacent to the cuboid. These bones ossify between 1 and 3 years of age and fuse by adolescence around 13 to 15 years. A particularly important clinical correlation is the second metatarsal keying mechanism into the mortise formed by the cuneiforms. Because of this rigid articulation, fractures or dislocations here are hallmarks of the Lisfranc injury, one of the most severe and disabling midfoot injuries. Recognizing this relationship is crucial for radiographic interpretation and surgical decision-making. Additionally, the tendons of tibialis anterior, tibialis posterior, and peroneus longus insert around the cuneiforms, emphasizing their importance as anchor points in maintaining the arches of the foot. The trapezoidal shape of these bones contributes to the stability of the transverse arch, reinforcing the structural integrity of the midfoot. Summary. So, to summarize this section, the talus is a bone without muscular attachments, highly vulnerable to vascular compromise with key landmarks like the neck, posterior process, and lateral process. The navicular acts as the keystone of the transverse arch, with the posterior tibial tendon inserting at its tuberosity. The cuboid anchors the lateral column, guiding the peroneus longus tendon. And the cuneiform bones articulate in a way that locks the second metatarsal into place, ensuring stability, but also making this region prone to Lisfranc injuries. Together, these bones form the foundation of the medial and lateral arches of the foot, balancing stability with flexibility and enabling the complex mechanics of gait. In the next part of our lecture, we will continue exploring the phalanges and sesamoid bones and link these anatomical details with their clinical implications. Having now explored the hindfoot and midfoot, it is time to complete our journey by analyzing the forefoot, focusing on the metatarsals, phalanges, and ossicles. These structures, although smaller than the tarsal bones, play an essential role in weight transmission, balance, propulsion, and fine adjustments during gait. Their anatomy may look straightforward, but when studied in detail, we see how complex and clinically significant this region truly is. Let us begin with the metatarsals, which form the long bones of the forefoot. In the dorsal and plantar views illustrated, you can clearly identify all 5 metatarsals, numbered from medial to lateral, 1 through 5. Each metatarsal consists of a base, proximally, a shaft, and a head, distally. The first metatarsal is the shortest yet the strongest, reflecting its function in bearing the majority of body weight during push-off in walking and running. The heads of the first and second metatarsals in particular are subjected to immense forces, making them critical in biomechanics. The base of the second metatarsal is wedged between the cuneiform bones, forming what is known as the keystone of the Lisfranc joint complex. This anatomical arrangement is extremely stable, but when disrupted, results in the severe injury known as the Lisfranc joint fracture dislocation. These injuries, often seen in athletes or after high-energy trauma, are notoriously disabling if not diagnosed early, highlighting the clinical importance of recognizing the structural interlocking of the second metatarsal base. Another point of note is the head of the first metatarsal, which possesses a crest separating 2 small grooves that accommodate the medial and lateral sesamoid bones. This crest and the sesamoids together form a pulley system for the flexor hallucis brevis tendon. This anatomical detail may seem minor, but clinically it is critical. Sesamoid injuries, fractures, or sesamoiditis are common causes of forefoot pain, especially in runners, dancers, and individuals with hallux valgus deformities. Speaking of ossification, the metatarsals display a fascinating pattern. The shafts ossify early, around the 9th week of fetal life, whereas the secondary ossification centers at the heads appear later, between 5 and 7 years of age, and fuse during adolescence, around 14 to 18 years. An important exception is the first metatarsal, in which the ossification center is located at the base, rather than at the head. This distinction is not just a trivia fact, it has diagnostic significance in pediatric radiology, allowing us to distinguish normal development from pathological changes. Now, let us move to the phalanges, the small bones of the toes. Each lesser toe, from the 2nd to the 5th, has 3 phalanges, proximal, middle, and distal. The great toe, or hallux, is unique in having only 2 phalanges, a proximal and a distal, but despite being shorter in number, they are robust and essential for push-off strength. In total, there are 14 phalanges in each foot, 28 when considering both feet, and their collective alignment ensures stability and precise motion. Ossification of the phalanges begins around 10 weeks of fetal life for the primary centers, with secondary ossification centers appearing between 2 and 3 years of age, and final fusion by late adolescence, between 14 and 18 years.
The growth plates are usually located at the bases of the phalanges, and once again, each phalange ossifies from a single center, except for the hallux, which can occasionally present with a bipartite distal phalange, an anatomical variant that must not be mistaken for a fracture. Clinically, the phalanges are extremely important in conditions like hammer toes and claw toes, deformities often associated with imbalance between intrinsic and extrinsic foot muscles. Rheumatologic conditions, such as gout, frequently target the first metatarsophalangeal joint, producing redness, swelling, and severe pain, often referred to as podagra. Fractures of the phalanges, while common, are usually treated conservatively, but dislocations and malunions can severely impair function, particularly in athletes. Between the metatarsals and phalanges, we also find the tarsal tunnel region, a fibro-osseous passage formed by the flexor retinaculum on the medial side of the ankle. Within this tunnel pass the tendons of tibialis posterior, flexor digitorum longus, and flexor hallucis longus, along with the posterior tibial artery, vein, and nerve. Compression of the tibial nerve here produces tarsal tunnel syndrome, a condition analogous to carpal tunnel syndrome in the wrist, resulting in burning pain, numbness, and tingling along the plantar aspect of the foot. This is another example of how detailed anatomy translates directly into pathology. Finally, let us address the ossicles of the foot, which are small accessory bones that can be normal variants or sources of clinical symptoms. The sesamoid bones, as already mentioned, are embedded within the tendons of flexor hallucis brevis beneath the head of the first metatarsal. They act as fulcrums, increasing the mechanical advantage of flexor tendons, but when fractured or inflamed, they become a significant source of pain. Other common ossicles include the os trigonum, located posterior to the talus, which represents an unfused lateral tubercle. While asymptomatic in many individuals, it can cause posterior ankle impingement, particularly in ballet dancers or soccer players who frequently plantar flex the ankle. The os peroneum, located within the peroneus longus tendon as it courses around the cuboid, can also become fractured or symptomatic, mimicking lateral foot pain syndromes. Even the accessory navicular, located medially near the navicular tuberosity, can be problematic, as it increases the prominence of the medial foot and predisposes patients to posterior tibial tendon dysfunction. Thus, when we analyze the forefoots from both the dorsal and plantar views, we see not just a collection of small bones, but an elegant arrangement of levers, pulleys, and weight-bearing platforms. The metatarsals transmit forces from the hind foot to the ground. The phalanges stabilize and propel the body forward. The sesamoids optimize tendon function, and the ossicles, though often dismissed as incidental findings, can play a decisive role in pathology. In conclusion, the forefoot is a masterpiece of structural engineering, finely tuned for locomotion, balance, and adaptability. It is here that the body meets the ground, and even the smallest deviations in alignment or anatomy can result in significant clinical problems, from hallux valgus to plantar fasciitis, from stress fractures to tarsal tunnel syndrome. This completes our discussion of the osteology of the foot and ankle, integrating the hindfoot, midfoot, and forefoot. Together they form a dynamic structure that supports the entire body while allowing for both stability and mobility. In the next section of our lecture, we will build upon this foundation by exploring the detailed ligamentous structures and joint mechanics which further reveal how this complex system achieves its remarkable function.